Good evening, everybody. Welcome to our session, our live Facebook session on vaginal breech. Here in India, thanks to the term breech trial, a lot of our obstetricians have lost the skills. And I think it's time we start looking at it with fresh eyes. And who better than professional midwives to lead the way here? We're privileged to have 3 professional midwives here, and we've got Shawn, Dr. Shawn Walker, who's been doing a lot of work in vaginal breech and the safety of breech births, vaginally. So Shawn is going to answer a lot of questions from you. And we've also got Kaur, who's been at Fernandez for about a year and a half. And she's from the Royal London. We've got Kate Stringer, who's joined us about 3 months ago, and was also a part of the professional midwifery services here in Fernandez and helping to train. Both Indy and Kate have been helping to train nurses into midwives, both at the public hospital and at Fernandez. Shawn is here for a brief period, and we're privileged to have her here. She's running hands-on workshops. Over to you, Shawn.
Thank you, Dr. Evita. I am very honored to be here with these 3 amazing professionals and with Fernandez Hospitals, who are at the forefront of compassionate maternity care here in India. And the purpose of tonight's Facebook Live is to talk about what are the possibilities for increasing skills around breech birth here, firstly in Fernandez, but also because this is an ambitious group of people across India. One thing that should be said is what I study is something called physiological breech birth, and that is where the mother births in the position of her choice. Usually that is upright and slightly forward-leaning, such as kneeling positions or hands and knees, sometimes squatting. So those are the techniques that I've been teaching, because the purpose is to increase the safety of breech birth itself. And the research indicates that when women birth in the position of their choice, in a physiological manner, that the second stage, the pushing stage of labor, is shorter, that there are fewer injuries to both mother and baby, that there are fewer needs to use maneuvers, and that you have a lower cesarean section rate associated with attempted breech birth than when the woman births on her back in classical supine methods. So that's just to give you an introduction to the type of breech I'm teaching. And should I say something about myself?
Yeah, and also say hello to Sheena.
Hi, Sheena. Oh, hi, Sheena. Nice to see you here. So just to let you know a little bit about my background, I am a midwife. I'm also a PhD, and I'm a lecturer at King's College in London. So I research how professionals become competent and acquire expertise in physiological breech birth, and then I translate that research into training programs to make breech birth safer. So I understand that we have a number of questions that people would like to ask here to our panel, and I'm happy to answer whatever questions that you have. Yes, we have already got 2 questions, and so I'll just start with them. First one's really simple to answer. Is a natural birth possible with placenta previa? For those of you who aren't aware, placenta previa is when the placenta grows over the cervical opening of the womb, so the lower os opening of the uterus, and the answer is no. That is one of the reasons that sometimes babies are breech. So if a baby is breech because of a placenta previa, that needs to be a surgical delivery by cesarean section. So what we're concentrating on is the women and babies who are otherwise fairly low risk of complications, that if the baby were head down, there would be no question that this woman would be attempting a vaginal birth. If there's a clear indication for cesarean section, that's not an appropriate situation where it's safe to try a breech birth. The other question is breech birth good for the babies? And that's the big question, isn't it? Because, of course, the term breech trial indicated that breech birth isn't so good for babies, and that is one of the things that sealed the nail in the coffin for breech birth skills. That's a bit more of a complicated question to answer. The term breech trial initial study report focuses on short-term results, and most of the studies indicate that in the short term, I mean immediately after birth, babies who are born by cesarean section do marginally better. So if you want to look at an outcome like neonatal mortality, where the baby sadly dies, you could expect that to happen about 1 in 200 births, 1 in 2,000 births for a cesarean section, and about 2 per 1,000 births in a vaginal breech birth. So there's a noticeable difference, okay? But it's not such a huge difference that it makes that option an unreasonable option. Because the other thing is, when you get to long-term outcomes, so at about 2 years, if you look at the difference between people who've planned a cesarean section and people who've planned a vaginal breech birth, the outcomes of what we call a composite outcome, that means babies who have died or shown significant delays or problems at 2 years of age, and we put those all together because any one thing in those categories is too small to measure. So we put them all together and we compare, and it is actually 12 in one and 13 in the other. Okay, it's actually equivalent. There's no greater risk from vaginal breech birth when you look at long-term outcomes. None of the studies have indicated that. And of course, when we're talking about is breech birth good for the babies, we also need to consider future babies. So about 65% of all breech babies are to first-time mothers, and especially in a country like India, many of those mothers will go on to have more babies. And not having a cesarean section makes that considerably safer for the baby, definitely, but also for the mother. For the mother, it's very clear that having the option of vaginal breech birth for first babies very significantly reduces adverse outcomes in subsequent pregnancies. And what I mean by that is there's less severe bleeding, less maternal mortality, and other sorts of things that we want to avoid for mothers. And of course, even for that first baby, where women are able to achieve a vaginal breech birth, they're better able to care for their babies. So they're better able to bond, to feed their babies, to establish breastfeeding, and of course, this in itself is very good for the baby. So that's one of the reasons why Fernandez Hospitals is looking to reduce cesarean section rates and how Breech can help with that.
Thank you, Shawn. You've raised a very valid point in terms of the primary and breech and avoiding a C-section, because if we can avoid that primary C-section, particularly when you have 26 million births, and if you look at 3% of them being breech, you're talking about huge numbers. So I actually looked at some of the videos and I was fascinated. And I'm only sorry that I'm not in clinical practice anymore. I'm very, very envious of the obstetricians who are going to attend your workshops. Thank you.
We've got a couple of questions on the screen. Deepa. Hi, Deepa.
Hi, Deepa.
Deepa's question is probably many obstetricians say that to women, like the risk doubles for a breech birth than cesarean section.
Mm-hmm. Well, actually, if you think of the stats that I just quoted, which are from the RCOG guideline, the risk quadruples, which is even worse, isn't it? But that's why the RCOG guideline, and by RCOG, I mean Royal College of Obstetricians and Gynecologists, because I am UK-based at the moment at King's College in London, so we follow that guideline throughout the UK. And the guideline, as I said, indicates that the risk will be about 2 per 1,000 for a vaginal breech birth and 1 per 1,000 for a cesarean section. So actually it quadruples. But that's why the guideline says that we must give women the information in relative form, which means it doubles or it quadruples, as well as the absolute risks. which is the numbers that I gave you, because those numbers will mean something different to every woman. And it's right that she has the information in a format that she can understand and which puts the risk into perspective, because the risk is still quite low. Regardless of the choice that you make, the most likely outcome is a healthy mother and a healthy baby at the end of whatever your decision is.
And also, thank you. We've got Laura Zurich. Ciao, Laura, all the way probably from Italy. And we've got Elizabeth as well. Thank you for joining us. Deepa, I hope that's answered your question as well. In fact, more detailed statistics too. So do come up with any questions and we can interact within the group. Yes?
Yeah, definitely.
Cool. We're very happy actually to have Shawn here. She's been to our trainee site, and 30 trainees in a state in Telangana have been trained, and it's such a vital skill because they are going to be going back to the PHCs and use the skills because they're going to have a lot of undiagnosed breech turning up.
Yeah, I think PHC, for those of you who are coming in from the UK, is Public Health Centre. Primary Health Centre. So the Primary Health Centre will be probably in a remote, more rural location. So not all of these breech babies are diagnosed. Even when I did an audit in a UK setting where I worked as a breech specialist midwife, we were missing anywhere from 20 to 30% of breech babies, which sounds really not so great, but it's actually not so unusual. And in a UK setting, that isn't such a big deal because the women will just transfer to an obstetric setting where possible. But clearly, if these women are giving birth far away from medical help, it's really, really important that the healthcare professionals caring for them know how to manage these emergencies. And many of the midwifery trainees who are completing the PMED program here said to me that they were very, very worried. It's not uncommon that breech birth is a health professional's greatest fear with obstetrics, that you can imagine all of the terrible things that might happen and worry that your skills won't be up to scratch. But the purpose of the training is to give people confidence that they can recognize when something's not going right, and so that they know exactly what they need to do to intervene. And we practice that over and over again with videos and then with hands-on practice.
Cool. Hi Nibia and Nazaruddin. Do write the questions if you want to ask us any questions, and our breech specialists and
I've just been with the students in the rural town today in the public hospital with India's first batch of professional midwives, and they were very excited by your training. They found that your techniques were very simple to use, and they felt that they would be able to remember them very well, and that they felt that the assessment skills of the newborn that you'd given them would really help them actually in supporting all births, but the ability to know when they needed to intervene more sooner was really going to stay with them, and they were delighted for your visit. So thank you very much for helping us inspire this new batch of midwives in India.
Thank you. May I ask a question?
Sure.
How did they respond to delivering a breech with a woman on all fours? Because that was something completely new. I'd love to, what were the expressions on their faces and their responses to it?
They soaked it up. They were very receptive. And one of the great things about assisting women to birth in that position is that you see so much more. You see the front of the baby, you see the cord, you see how baby is moving. And baby does have movements in a supine position, but the baby is actually facing down and gravity is pulling the baby down, so you can't see if a baby does what we call a tummy tuck, where the baby pulls the arms and the legs up into a fetal position. And that is part of the way that babies actually assist their own births when women birth in physiological positions. So like Kate said, one of the things that I love about teaching breech is that it's a catalyst for so many other things. So I might just seem to be teaching this tiny little niche of midwifery and obstetric knowledge, but actually so many of the skills are translatable to the rest of practice. Indeed, as I teach around the world, I've seen, for example, hospitals which have an 80% epidural rate plumb in Entonox, inhalable analgesia, for the first time, so that women can give birth without epidurals to facilitate breech births. But that then means that every woman has that option. And many obstetricians in different countries have all come up with the idea, maybe we should practice supporting some women with cephalic head-first babies to birth on hands and knees, so that we can get used to this new idea. And I think as a midwife, that's a fabulous idea. So I think breech birth takes you out of your comfort zone and enables you to see the way you can do things differently. And also, some people feel, why are you concentrating? Breech birth shouldn't be the priority. I've often heard that. We have so many other priorities. But the thing is breech birth is often the one thing that people say, oh no, we support normal birth in all reasonable situations. We only have sections for something like breech, which seems really obvious to everyone. But if you take that obvious indication for a section and you say, that's not so obvious anymore, then, VBAC seems like a breeze. Someone having a vaginal birth after cesarean section, simples, right? And you don't have time to worry about the midwives who are putting women in the water, because you have to concentrate on things like breech birth. So it is a catalyst for other things which affect the overall approach to birth within a unit.
Cool. And so another question that's come up via Deepa as well, saying that do doctors, because the art is dying, do we need special training because there's safety issues? So do staff need special training, or all midwives be able to facilitate breech birth?
Well, this is a key question as well, because we know that the safety of breech birth is related to the expertise of the people attending it. However, there are different ways to develop expertise, and that's one of the things that my research is about. So traditionally, what happened was, in places where there were high breech birth rates, midwives and doctors attended more breech births, and so they had a certain amount of personal experience. I think maybe in the good old days, as people like to remember in very rosy terms, they probably had a higher tolerance for some adverse outcomes as well. So even if each individual midwife and doctor had experience of delivering 20 breech babies across their career, 20 is still a pretty small number, okay? So other ways that you can increase your skills and knowledge without actually attending breech births is by watching videos and by having really clear theoretical training. So that's what we're doing with the training that we're offering. We're kind of trying to hothouse approach the kind of pattern recognition that you would get by attending 50 breech births. So I do that work for you in a way. I watch 100 breech birth videos and analyze exactly what's going on in them and which situations are leading to complications and which situations are leading to really good outcomes. And then I make that information readily available so that you don't have to figure it out on your own. You still have to get some clinical experience applying it, but we practice in simulated sessions. We practice with videos that are alongside the dolls and pelvises that we're using to do the maneuvers, so that you know when you see, the baby hasn't rotated, it means there's a problem with the arms and now I need to intervene. So that's how we're trying to address it. Yes, I do think one of the things that we need to be aware of is if people don't have expertise, the risk is a bit higher, okay? But what many units are doing is they're identifying breech champions or breech specialists, which are people with a special interest who have bothered to come on and watch all my videos that I've created, and they've gotten training from other sources, and they've compared it, and they've done their own thinking, and maybe they have a little bit more experience than other people in their unit. And the plan is that when the woman goes into labour, they're going to be called, and they're going to support the wider staff to attend breech births. So the specialist model is not one in which a small group of people have exclusive skills. It's one in which a small group of people have significant skills, and they can then form the safety net for other people to increase their skills.
Perfect. Yes. We've got some hellos there. Sheena has got 4 claps in her hands, and Samantha Kumar, hi. If you have any questions, do ask us whilst Shawn is here and Kate is here and Evita is here. Someone said, Evita, you birthed me not so long ago. And we've got Vailaba Galfu. Sorry if I pronounced the name wrongly, but hello, thank you for joining us. Any questions, do write them and we'll go through them as well.
So developing that specialist team is exactly what we're hoping to do here in Fernandez, so that we can start to cascade this training out to the rest of the team, and so that at Fernandez we can start to offer vaginal breech births to all women who want them, rather than making these individualised choices, and us being able to support them with the right skills.
I think that's so important, and if you are watching from Telangana or Hyderabad, please do share the information with your friends that this is going on in Fernandez hospitals, and I understand there are other places that are beginning to facilitate breech births or have been doing for a few years as well, but that way, if you know someone has a breech baby and you know that they want a normal birth, maybe they're planning to have a large family, or they have other reasons that that's important to them, you know who to refer them to. Because ideally, you'd like to develop a specialist centre as well, where everyone has a significant level and that it's not hit and miss. And it will be hit and miss for a little while until everybody knows actually we are doing this. But one thing that's amazing about Fernandez is that they have such regular teaching sessions that I know that whatever breech births occur here, they're going to continue to learn from and share with each other to keep developing the skills, and gradually the entire team will get to know that this is what happens here, and more and more women hopefully will have some positive stories to share with each other.
It's a good point, because the Breech champion doesn't just limit to midwives, it's midwives and obstetricians.
Totally.
So it's a multi-collaborative model.
And that is why Fernandez hospitals are an ideal place for this type of initiative, because the respectful environment that I've experienced here, I have a hard time distinguishing sometimes who actually is an obstetrician and who's a midwife, aside from the fact that midwives wear the characteristic shirt and pants that they are known for throughout Telangana. But the doctors are also very committed to normal birth. They're very interested in the midwifery initiative, and so I know that they're going to support the midwives to develop their skills, and that it's a team that isn't going to undermine each other, and that's so important because obviously you need midwifery physiological skills to help keep it as normal as possible. That's what helps make this type of breech birth very safe. But you also need obstetricians who are going to be able to act very quickly if this does need to change to a surgical delivery, because that will sometimes happen, and that's still a good outcome. That's still a good outcome.
Great. Deepa is thanking you for explaining that very clearly, Shawn.
Pleasure.
And Sarah Bennett, hello.
Hi, Sarah.
Sarah, she's loving that this is happening. Hit the equation, breech, and with cesarean section, and that's what Shawn's just been through earlier. Breech goes for an automatic cesarean section, and that's why we've got Shawn here to help us to reinvent and breech vaginal births.
Of course, there are other options as well, and the team here is already doing things like spinning babies. When it is discovered that a baby is breech, they're giving women the options of trying certain exercises to create room for the baby to move, and they are also offering external cephalic version, which is a method of trying to turn a breech baby to head down in the uterus. And certainly I have found that different options work for different women. You know, some women, let's face it, some women are thrilled that their baby's breech because they actually want a section, and now we don't have to debate it anymore. And I don't really think we're in the business of convincing women that they need to have a vaginal breech birth. Other women really wanted a water birth. They really, really wanted that. And at the moment, we're all in agreement that it's one step at the time. So there are no immediate plans to offer breech water birth. So for that woman, an external cephalic version is a good plan, okay? But for the woman who tries that and it's unsuccessful, or sometimes women just feel, you know, my baby has chosen this position, I trust the birth process, and I just want to let it happen as it's going to happen. Some women will just want to try for a vaginal breech birth. And some of those women, especially if it's a second baby, will find that when they wait to go into labor, baby will finally get themselves into gear anyway and end up head down. So I've found that a lot, that if you're just patient enough to wait, quite a few of them will just turn by the time they go into labor anyway.
Perfect. And we've got Asuri Shanti. Hi Ashuri, Buju Hani and Mohini. Thank you for joining us. Shawn, one question that keeps on coming up is primogravidus and multigravidus. What's your take on that?
Okay, so the research indicates that when first-time mothers, so primies or primogravidas, you have primates, that's kind of midwife and obstetrician speak for first-time mothers, have breech births, the outcomes at 1 minute, the babies are often a little bit shocked. So at 1 minute, the measurement that we take, which is called an APGAR score, named after an obstetrician, a pediatrician named Virginia APGAR, which measures how well the baby's breathing, what the color of the baby is, how much the baby's moving. Those are often, and I do say often, because when I counsel first-time mothers, I often say, let's just expect that baby will need stimulation and or resuscitation at birth. But the thing that we keep in mind is that by 5 minutes, those scores are no different in the majority of the research than they are for women having a second, third, or more baby. And that's why that guideline that I spoke about, the RCOG guideline, doesn't even mention parity, how many babies a woman has had. It is because the evidence doesn't indicate that it makes a difference. It certainly makes a difference to people counseling women because it's more scary. You have more fears when that baby comes out shocked. But the other reason that this is and the reason that the baby comes out shocked is just that it's a slower journey down through the maternal pelvis when it's a first baby, because it's the first time something that big has gone through there, and it's just more chance of cord compression, okay? And so the baby gets a little bit shocked when they come out. But one of the other reasons that Fernandez is a good environment to try this out on, or to introduce this here in Hyderabad, is that the midwives especially are fairly consistently practicing optimal cord clamping. So they are waiting for at least a minute, if not more. And certainly while I've been here, we've been at births together, haven't we, Indy, where we're supporting the midwives, and we have had the bag and mask ready to start and to initiate resuscitation on the cord if it's required. So usually our standard procedure with a physiological breech birth is if a baby comes out shocked and we feel that we need to initiate resuscitation, what we call the inflation breaths, these are the big breaths that we put in to expand the baby's lungs, we will do those on the bed with the cord attached. So oftentimes, by the time you finish that, the baby's crying, the cord has filled up, the baby has gotten oxygen from the placenta and the inflation breaths. So you're in a win-win situation. If not, or if you're having difficulty achieving a good inflation breath, and you decide that you need to go to the resuscitator, babies have that whole length of time to get more blood. And the thing about a baby that's compromised is that when you are resuscitating, the more blood that the baby has in the baby, the more successful the resuscitation is going to be. So for breech babies where compromise due to hypoxia or low oxygen is a real issue, we want that baby to have as much blood with the cord filling back up from the placenta as the baby can, so that when you start resuscitating and circulating the blood around the baby again, there is more blood to oxygenate the brain and the heart.
Thank you. That's really clear and good for the midwives and the team as well to learn. And we've got Swapna online saying hi, and Georgina Sosa. Hello,
Hi.
Georgina.
Hi, Gina.
Hi.
So, there's no question. Okay.
Yeah, there's no questions yet, but Dr. Evita, what are your thoughts about the?
No, I'm just listening to you, Shawn, and I'm so fascinated because we obstetricians years ago would just take the baby away, and this whole concept of delayed cord clamping, resuscitating the baby while the baby is on the mother's abdomen, is a whole new way of thinking, and I just think it's revolutionary in many ways, and I really look forward to us understanding this. And once we really get our act together, then we encourage others to do this, disseminate this across the state.
Great. Everybody at home, if you want to ask us any questions, we are privileged to have Shawn Walker here, Dr. Shawn Walker, and she's been here for a week, and she's done a lot while she's been here in Hyderabad and in Telangana. So I must say, she hasn't stopped, and we're not going to let her stop. So do ask some questions, and we can answer them too.
Hi, Gina. So good to see you.
Shawn, just going back to the difference between, primates and multips, would you say that that all primates, regardless of whether it's cephalic or breech birth, those babies are slightly more likely to need assistance at birth? Is that correct?
Yeah, I think that we see that difference with primiparis women as well for head-down babies. I mean, even if you look at something like the birthplace study in England, which is one of the largest pieces of midwifery research ever undertaken to see about whether the outcomes were the same or different, depending on someone's choice to birth at home or in a midwife unit or an obstetric unit. And for first-time mothers, they found that it was safer for the baby, for women to be in a midwife unit, either freestanding or alongside, or an obstetric unit, that there were visibly different outcomes for the first babies who were born at home. But again, the number of those outcomes, although it was apparent, it wasn't so different that in the UK, giving birth at home is still considered a reasonable choice for a first-time mother to make, because one of the other findings was that the outcomes for women were significantly better the further away from an obstetric unit you got. So the outcomes at home were still very good, and again, there's all sorts of reasons why someone might choose to do that anyway for a first baby. And so it's kind of comparable. The fact that you can see a difference, that's only one outcome that you're looking at in a piece of research. The actual informed decision-making process takes into account the woman's family situation. It takes into account the woman's needs, wishes, and values, and those aren't captured in a single piece of research. Those all come from very different places. So increasingly, and especially in a place like Fernandez Hospitals, where they're really trying to pay attention to collaborative care with women, we're giving women options that are aligning with their values and what's important to them, and not just what one piece of research says is best in this one way. I hope that makes sense.
Yes.
Makes a lot of sense. Hi, Sarah Benetti. Sarah is a doula, fully supporting women's choices, and had a case 2 years ago with a client struggling to find a consultant willing to take in consideration with her wishes. She was expecting twins, and they both were breech. She ended up finding a wonderful consultant in Northern Ireland, having twins in a very calm twin breech water birth, and she was aware of the possibilities and the complications, and she and the consultant talked about them and the actions, and she catched the babies herself, had delayed cord clamping, and nursed twin 1 and twin 2 was born, and she felt respected and supported.
Wow.
Thank you for sharing that story with us.
That's a very brave obstetrician.
Well, yes, I agree with you, Dr. Evita. And one of the things that is very special to me about the work that I do and the contact I have is I'm fairly certain I've heard this story from the viewpoint of the obstetrician as well. And that is often the case, that I will hear a special story like this from different viewpoints. And obviously, as a doula and a woman, you don't see what goes on outside of the room that you are sharing that decision-making process with the obstetrician. And I think that one of the barriers that is very significantly revealed, it's revealed in my research, it's revealed in other pieces of research as well, is that practitioners, whether they be obstetricians or midwives who support breech births, come under a lot of pressure from others who do not want it to happen. Okay? And there is often the experience, I'm not saying it happened in this case, but in general, the experience of actual kind of violence and abusive behavior, and the attempts to curtail the practice of people who are even practicing safely. And that might not be something that everyone is willing to do, but I think in that case, that consultant was familiar with water birth, and she's familiar with twin birth, and she's familiar with breech birth. And in her opinion, it was safe enough, if the woman was had an informed choice, for her to facilitate that birth. Where there were 3 different variables that introduced something different, but she was familiar with all of them. Now, I absolutely agree that your average obstetrician is not going to feel that way, okay? But she did. And I probably even shouldn't be calling her she, but there you go. Getting used to Facebook Live.
Maybe we're assuming it was a woman.
Maybe I'm assuming it was a woman. But anyway, but what I want to call into consideration is that midwives, obstetricians, and women need to work together to ensure that this choice is available. And it's absolutely important to recognise that when someone does go out of their way to support a breech birth, that they often do that at considerable risk to themselves professionally. It shouldn't be that way, but that is the way it is.
Wow,
yes.
Thank you.
Yeah, it's very interesting. Yeah.
Hi, Hannah.
Hi.
We've got, Hannah, hi. Vinita, hello. Mohini, hi. We're getting loads of joy. Brilliant. Sheena, you are so kind.
Sheena's great.
Yes, Sheena is our advocate too.
Yeah.
Well, I would personally feel very apprehensive offering breech in water. I'm confident with water births, but it's outside my remit, and I feel that that's a very brave decision to do.
Yeah. So on the course, I always cover breech water births, and there are 2 reasons for that. The first is that the most common situation that UK midwives encounter breech births is something like this in a water birth. Oh, that's it's a lot of hair. Actually, that's meconium. Okay, that's a bottom. Pull the buzzer, there's a baby. That's the most common situation in which UK midwives encounter breech births, because water birth is very, very common. So I'm often asked by midwives, what should I do if I find out the baby's breech? And the answer that I give is, if you are not confident with both, if it were me at 8 centimetres, I probably still would offer the woman a choice, because I'm very confident with both, and I have studied breech water births and how people do it, even though I haven't attended one, which I would share that information, but I would feel okay myself offering that choice. But if I hadn't attended a breech birth, or I've attended just a few and I wasn't totally confident, if I did a vaginal examination and found out at 8 centimetres this baby's breech, or I saw a string of meconium and that's what alerted me, I would probably say, I think the safest thing to do is to get out of the pool and to set up your resuscitation equipment, to notify your backup, and to get that ball rolling and prepare for a calm breech birth out of the water. However, if the first time you realise the baby is breech is when the bottom is emerging, I think that the safest thing to do is to take a deep breath, set up your resuscitation equipment, notify your backup, and watch that baby come at you. And if it isn't coming quickly, you have a very low threshold for changing. But like with shoulder dystocia, we know that if you have a shoulder dystocia in the water, usually the maneuver that works best is getting out of the water. So essentially, you've got a maneuver in your back pocket. If something slows down and you think there's going to be trouble, then you just get her out of the water and make sure you catch the baby when it falls out. So I think that is what I would say is a fine way to manage that particular situation, because what you're going to do, you don't want to panic the woman as things are happening. Oh, emergency, we need to get out now. Do that if it's an emergency. But if it's not yet an emergency and the baby's half out, let the baby keep coming.
Yeah, it's a good point. Yeah.
I've been in that scenario actually, and the first thing I saw was the wellers looking, and then appeared a scrotum, and as my mind was whirring, the rest of the baby was born. So I didn't really have time to do anything, and actually I felt very confident that the baby's heart rate had been perfect beforehand, and she was clearly labouring very quickly.
Yeah, and this was in water.
Yeah, in water, yes, and there wasn't. By the time I was thinking, is that definitely it? It was coming, so we didn't need to do anything, and actually the baby was great.
And the second reason that I always give it airtime is that I am a researcher, and I have a duty to report what emerges in my research. And my research indicates that of my panel, I did a piece of research which was a piece of consensus research with highly experienced practitioners, 13 midwives and 13 obstetricians and 2 service user representatives. The average number of breech births that panel had attended, and this is the average, was 135 breech births. Okay, 2 of them, 1 doctor and 1 midwife, had attended over 400 breech births.
Wow! They must have worked so hard.
Well, interestingly, they both worked in America, which everybody says, how can that be? This is the land where everybody gets a C-section. But it is also a land which is modelled on continuity of care systems. So if you develop a reputation as someone who will attend breech births, people will literally come from out of state and rent an apartment. And I've been at a birth with an obstetrician where a woman rented an apartment with David Hayes in North Carolina. Somebody rented an apartment to be near to him to have their breech baby. So clearly that these people are attending high numbers because people are coming in. And this is what happens when you become a centre of excellence as well. That you look at Anke Reiter's hospital or Frank Leuven's hospital in Frankfurt, Germany, they have a 14% breech birth rate. Gosh. Not because all the babies are breech, but because people come in. So 14% of the babies born in their hospital are breech babies. So of my panel, 52% of them, and they were not all midwives, some of them were professors of obstetrics, so highly regarded, highly intelligent people who had decided, this actually has some merit, and they reported having attended breech water births. So as a researcher, I can't ignore that, okay? I have to say, because we shouldn't be just immediately dismissive just because it makes us uncomfortable. However, I also think we need to be reasonable and to say, when you introduce breech birth into your own practice or into a new unit, it's probably best not to start with breech water birth, just like it's probably best not to start with women who have a lot of other complications.
Right.
It's probably best to start with someone who's had a baby before. Probably it's best to start with someone who has no other complications. And you build up that practice. And when you get to feel, I'm pretty good at this, then when you get someone who says, no, I really feel I need to be in the water, well, then you can make your decision. Is this something I'm ready for, or is it something I'm not? But this was actually feedback that I gave in the peer review process for the RCAG guideline, because they said, well, it's not recommended. And I said, you actually need to back that up with evidence. If you don't have any evidence, just don't mention it. You don't need to say we don't advise it, because you need evidence to say we don't advise it. But you also don't need to say we support it if you don't have evidence to support it. But I think that evidence is yet to come. We don't have it yet.
That's a very good point, actually. We've got Tejo online. Hello, Tejo. Any questions on the neonatal perspectives? Do type them in.
Neonatologist.
Yes.
Hi, Tina.
Sarah is saying.
Hi, Tina.
Oh, yes, Tina, and we've also Celestina. Hi, Celestina.
And Linda.
And Linda, yes, Linda Quinn. She's
Hi,
loving
Linda.
it. Great.
I thought that story gave us a very good insight, though, into how important breech vaginal birth is for some women. You said that there's women that will sometimes rent an apartment right next to a hospital because it's that important to them to experience a vaginal birth or a breech vaginal birth. I think that is probably what's driving us all as professionals here to want to make this a realistic choice, because for some women it's really, really important for them, and we need to be able to offer these choices to them in a safe way.
Yeah. And that's how I got into it. I was working as an independent midwife, basically because I had trained in the United States as well, and I was used to working in a continuity of care model, and I wanted to continue to caseload women because I felt that was for me, the way to achieve the best outcomes and to learn the most, because you see the consequences of your decisions. But in the UK at the time, where I was based in Norfolk, there was no way to do caseloading midwifery within the National Health Service as that is in the UK. So I came out of the National Health Service, continued to work on the occasional shift in the hospital, but I also carried my own caseload of private clients. And I was astounded because my second client wanted a home breech birth, which I said, I can't do that because I'm not experienced enough for that, but I can help you achieve that in a hospital setting, working with the NHS. And it became very, very clear to me that women wanted a care pathway. And eventually I worked with the unit where I had trained to set up a care pathway for women, and about 35% of the women who received balanced counselling were choosing vaginal breech birth. And other studies have shown about that percentage as well of eligible women, and I was counselling them using the term breech trial data, but just giving them that data, but also saying, but still any option is reasonable. That doesn't necessarily mean that there is only one option for you. And 35% were saying, I'd like to try for a vaginal breech birth.
I think that's important, women's choices, and also giving them a balanced decision making, not just caring women as well, but being honest and transparent and open. We've got a couple of new, Terence Gardner, hello. Celestina is saying it's so encouraging to see breech births can be done. Madhu, hi, is excellent. And Christine, just loving all the pro breech birth, because you've just been to Barts too, haven't you? So Christine,
I have been, oh hi.
Hi Christine.
London in the room.
Hope you're missing me. Cool. So
Yes, there were some very supportive obstetricians at Barts Health when I was there in July, and I think they're just setting up a breech clinic. So the way that a breech clinic works is that when a breech is discovered, the woman is referred to the clinic, and maybe the clinic will operate once a week, and then either the midwife or the doctor. So when I ran a breech clinic, I as a midwife was trained to do simple ultrasounds, so I could do head up, head down, the type of presentation scan, and there are many midwives in the UK who are trained to do that now. So I did the same training that specialist trainees do in basic ultrasound, and then about 3/4 of the women are actually head down, and so then that's an efficient use of resources because they haven't needed to go to an obstetric clinic or take up time in the ultrasound clinic. And then the remainder of the women I counselled about their options regarding ECV or vaginal breech birth or cesarean section. And we found in my setting that the uptake rate, means the acceptance rate of external cephalic version, basically doubled overnight because women knew I would be there, rather than saying, come in again and you'll meet someone that you haven't yet met and they're going to put their hands on your belly and it's probably going to hurt, but don't worry. You know, if they've had a chance to evaluate me and they know that they've evaluated whether I'm telling the truth when I say, but if you say stop, we will stop. If they trust that that's going to happen, we found that women, the uptake rate increases immediately. And so I was training to do external cephalic version. And there are many midwives in the UK now who do external cephalic clinics. And again, interestingly, because some people say, well, won't that interfere with obstetricians learning that skill? But in the places where midwives have acquired like really good experience, like hundreds of ECVs, such as Oxford, again, it functions like the safety net, that they are the ones who are training the obstetric trainees, and if they're not quite getting it, their more experienced hands are able to offer them some support so that they actually learn how to problem solve rather than just going in and having a very poor success rate because the trainees don't have the high levels of skill from doing hundreds of them. So again, they're functioning as a safety net and a training resource by having very, very experienced people available. And then as the breech specialist midwife, I was on call, and this is happening in many hospitals in the UK as well, where either a small number of people, sometimes it usually starts out with 1 or 2, you need a few white knights as you build up the service, who are willing to be on call, and they will again attend breech births and support the wider staff to develop skills. And then once more people have developed skills, someone says, oh, I liked that, I come again, and then someone else joins in the team. And certain hospitals, like for example the Westmead in Sydney, they've made it a desirable characteristic for obstetricians. So when they advertise a vacancy for a consultant post, they say this is a hospital that supports breech birth. So the person we're going to hire, we want them to either have breech skills or be willing to develop them. It's not a situation where we accept that you can just say, well, I don't do that. It's an obstetric skill and it's expected of consultant obstetricians.
Yeah, thank you, Shawn. I enjoyed what you just said, because I think as an organization, Fernandez Hospital should be committed to vaginal births, and that's the first step, to have you with us run these workshops. And you've given me another idea, so next time, that is one of the things we're going to ask for if anybody wants to join us. You need to support vaginal breech births. If you haven't learned the skill, we will teach you, but that is one of the non-negotiables.
wow.
Thank you.
Thank you.
And I've made this public, so I
We've got a few minutes left, so any last words from the panel?
Only that it's very exciting times here in Fernandez, and I think the choices and commitment to offer vaginal breech birth to local women is fantastic. It can have wide-ranging effects in Telangana and India eventually. So that's very exciting. So that's it.
Shawn?
I think we covered all the important bases today, and it's been a delight to be here. Obviously, I'm always available to answer any follow-up questions, and you will have information about the Fernandez hospitals and the midwives. You can always find me on breechbirth.org.uk. It's really hard to do a search on Google about breech and midwifery and not come across my blog. So I'm sure you'll be able to find it, and yeah, let's just keep the conversation going.
Is there still time to book onto your
Yes.
onto your workshops?
Yeah, the workshops are on the 12th, which is tomorrow, and on the 19th. If you're interested, just email us on the website and we'll get back to you. Or any other questions relating to breech, any women out there, if you want to ask us any questions, we will respond back on email. Dr. Evita? Sorry.
Yeah. I just also wanted to say, while we talk about all these videos, I want to take every chance that I can to say how grateful I am to the practitioners who expose their vulnerability and the women who expose their intimate private experiences so that other people can learn. The midwives and the obstetricians here have been so grateful, and I'm so grateful that you have trusted me with your birth videos, so thank you.
Thank you.
I would appeal to all obstetricians and postgraduates in OBGYN. If you haven't yet registered, you've got the chance to do so for tomorrow or Sunday the 19th. It's a wonderful opportunity. Grab it with both hands. Thank you, Shawn.
Thank you.
Kate and Indy, our professional midwives who are here to teach us, obstetricians and anybody else who's interested, all about vaginal breech birth. Thank you.
Thank you.
Very much.
Bye.